Welcome to Healthy Focus, the Duke Raleigh Hospital Community Education Series.
Please join me in welcoming Dr. Nikki. Great, good evening. Guess you can probably hear me with that microphone, right? Great. This evening I'm going to talk about urinary incontinence. And you're probably asking, why is it happening to me and what can I do about it? Well, urinary incontinence has been defined as an involuntary loss of urine that is a social or hygienic problem and is objectively demonstrable. And what that means is I've highlighted a couple of words which really characterize the problem. First of all is involuntary. You're standing at the grocery store, maybe you're in church, and you lose urine, and you really have no control over that. And that's really anxiety-provoking for many people. And the second word I highlighted is social, because it creates a social problem. It starts as a medical problem, this leakage that you have, but a lot of patients start to avoid interactions with family, friends, church members, because they're embarrassed about it. And they're embarrassed because of the hygienic issues. Is there an odor? Do I have wetness of my clothes that someone can see? And for that reason, a lot of people don't seek treatment. So I'm very excited that we have such a full room and everyone is here to learn about incontinence, but more importantly to learn that there are lots of options for incontinence. And I hope that everyone can leave here tonight with a better understanding of why this happens, what options are available for treatment, including medications, surgery, non-surgical things, and go out there and educate your family and friends so that they also know that if they have this issue, that they can find help, okay? I've already described some of my goals for tonight. The first is to give assurance that incontinence is a common problem. Then I'm going to discuss the ways that incontinence can affect your life, but I'm sure that you're very well aware of the ramifications of leakage. I'm going to explain the two main types of incontinence, and this includes stress and urgency incontinence. Many people do not realize that there's a difference between wetness and wetness, but there is. So we'll go into that a little bit. And I'll describe the conservative and surgical treatment options for the two main types of incontinence. First of all, you are not alone. Many women and men have incontinence. On the left side, you see that incontinence affects women of all ages. It affects young women less so than elderly women, but they did a study of Army recruits who were female. They've never had children, they were young, younger than 25 years old, and they surveyed these women who were in the Army, and 20% of them had incontinence when they were performing the rigorous exercises that you would expect when you're going through military training. And that's really surprising. You think of incontinence as being something that only afflicts the older generations, but it is not. It affects men and women, and of a lifetime prevalence of 11 to 13%. So, there are a lot of men in the audience. A lot of men here are here to be supportive, but you would be surprised that incontinence does affect both men and women. This is a little table, a graph that shows a prevalence of incontinence in women throughout the different age groups. As you can see, incontinence is less common in younger women. Then it starts to kick in around the time of menopause. That's when a lot of women say, I had a little bit of leakage before, maybe when I was exercising, but then I went through menopause and the leakage really became a problem. And after menopause, it steadily rises, more and more and more. Incontinence really affects your lives, and in various ways. Of course, it affects you in a physical manner. You can have skin breakdown when you're wearing pads every day, and that constant moisture down there can cause skin breakdown, rashes, skin infections. It has been associated with higher risk of urinary tract infections. Some people are rushing to the bathroom, and if you are asleep at night and you wake up and you feel this sudden urge and you don't move that well to begin with, as you're rushing to the bathroom, you can actually have a fall. And we have found a relationship between elderly patients who have incontinence and hip fractures, bone fractures, and other trauma that you can sustain after a fall, like even a head injury. Patients who have incontinence may avoid exercise. They don't want to get into a class and jump around, do jumping jacks, etc., because it makes their leakage worse. And for that reason, they're not doing the things they know they should do to help with their blood pressure, diabetes, etc. So all of those things really affect your physical health. But as you know, incontinence can also affect you in a socioeconomic way. There's a sense of embarrassment, social isolation. You withdraw from your family and friends, and then avoid intimacy with your spouse because of your concerns for hygiene. And if you have incontinence, those pads are not inexpensive. If you use 2, 3, 4 a day, I have some patients who come in with a bag full, 10 to 20. Can you imagine how much that costs? And if you're on a fixed income, like many of us are, that can be a huge financial strain. All of this leads to a decline in mental health. It really compromises your mental health. Patients have a lot of anxiety. When they go to the store or the mall, they know where every bathroom is. Trying to get onto a plane when you are afraid of leakage is very anxiety provoking. Some of this can lead to depression and certainly a decline in your sense of self-esteem and dignity. All these things really, really detract from your overall quality of life. Unfortunately, incontinence is a hidden condition. A lot of patients are embarrassed about it and they won't talk about it to their family members or their friends. Nearly half of patients are symptomatic for 3 years before they seek treatment. So they may have really bad incontinence and wait for 3 years before they mention it to their doctor. 59 of patients do not seek help because they believe that there are no effective treatments are available. And that's something I'd like to change. If that's a myth out there that we can't do anything about incontinence and it's just a normal part of aging, I'd really like to dispel that myth. In the end, patients take matters into their own hands and they self-manage by voiding frequently, reducing how much they drink, and wearing pads. My goal tonight is to educate, raise awareness, empower you, and then hopefully for some of you treat you. And then this is going to be a very strong spiral upwards instead of a spiral downward. Now I'm going to give you some education about incontinence. We're going to discuss the two main types of leakage. There is stress incontinence and then there's urgency incontinence. But a lot of patients have both. So I've drawn a Venn diagram and we call that mixed when you have both types of incontinence. This is a table that I've drawn to compare the two. Stress incontinence is here on the left-hand side. And this is caused by weakness in the pelvic floor and the urethral sphincter muscle. I think of a bladder like this, and the tube coming out is your urethra. In that tube is a little circular muscle, and it's supposed to shut tight whenever you cough, laugh, or sneeze. Basically, when your body is pushing down on the bladder. If that muscle is not strong, urine is going to leak through. And that's what happens in stress incontinence. So patients who have stress incontinence complain that they have leakage during exertion, exercise, coughing, sneezing, lifting their grandchildren, going to Zumba, all of these things I hear on a daily basis. On the other hand, we have urgency incontinence. This is caused by a different mechanism. A normal bladder is supposed to stay calm as it's filling. And then when you walk into the bathroom and you sit down, or you're standing, because this happens to men as well, you say, bladder, squeeze, and then it squeezes and you empty, right? Well, in urgency incontinence, the bladder does whatever it wants to, whenever it wants to. It doesn't wait until it's completely full. It doesn't wait for you to give it the command. It decides that it's going to squeeze right now when you're in, the line at Walmart, and all of a sudden you have to rush to the bathroom, or when the contraction is so strong, you may just gush urine. So I call it a teenage bladder. It doesn't, it just does what it wants whenever it wants. It doesn't follow any rules. Patients who have urgency incontinence complain of leaking when they're rushing to the bathroom. Sometimes when you go from a sitting to standing position, you feel a sense of urgency because the urine starts to, pool at the bottom of the bladder that triggers a contraction. Now that I've given you an idea of the two main types of incontinence, we're going to delve into stress incontinence. Here's a little cartoon, and it really depicts what I was trying to explain to you. You have a little muscle here, which is the urethral sphincter. You also have the pelvic floor muscles. These are all the muscles that create a bowl at the bottom of your pelvis and keeps you tight and strong. And whenever your body pushes down in the bladder, that urethral sphincter and your pelvic muscle, those two muscles are supposed to tighten up so the urine doesn't slip through. But when you have stress incontinence, it's too weak and you lose urine and you have some wetness. Since stress incontinence is due to the weakness in these muscles, treatment must target the problem, right? That makes sense. You identify the problem and then you fashion your treatment to target the problem. Here are some options for the treatment of stress incontinence which do not involve surgery, okay? And they include pelvic floor physical therapy. I'm sure many of you have heard of Kegel exercises. That falls into that category. We also have urethral inserts, pessaries, and vaginal estrogen, and that includes creams and pills and rings that you can use to supplement the estrogen that you don't have anymore after menopause. What I'll do is I'll describe each of these options in a little bit of detail. The first is pelvic floor physical therapy. You may know them as Kegel exercises. The way the Kegel exercises work is it strengthens those pelvic floor muscles and urethral muscles that we talked about, which is the cause of stress incontinence. I usually give patients tips on how to identify the right muscles because even though they've heard about them throughout their lives, it's like, no one ever really taught me how to do the Kegel exercise. I'm not even sure if I'm contracting the right muscle, and usually you're not. So if you can imagine, if you're in the bathroom at home and you're urinating, the muscle that you use to stop the flow of urine in the middle, that is the muscle that you need to contract when you do a Kegel exercise. I don't recommend doing it, on a regular basis on the toilet. Just do it a couple of times so you can identify the muscle. Another trick for identifying the right muscle is pretend you're in church or you're in the elevator and you're afraid you're going to pass some gas. And then you tighten up your rectal muscles, and that is also the group of muscles that you can use to do these exercises. When a lot of patients try these exercises, they start tensing up their abdominal muscles, trying to make a six-pack, and that's really not that's not the right group of muscles. So if you put your hand on your belly as you're contracting your muscles and you feel a lot of movement, you're not moving the right muscles, okay? Some things that you need to remember about a pelvic floor physical therapy is that you should not strain or hold your breath. This is a very subtle contraction of the pelvic muscles. In order for you to gain the benefit, you need to perform these a couple times a day. And you have to, just like any other kind of physical therapy, you have to continue and do it regularly. You may not notice a difference for 6 to 12 weeks. If you have a hard time identifying the right muscles, or you're maybe not getting the response that you want, we can look to physical therapists who specialize in the pelvic floor to help you identify those muscles. They also can use biofeedback to give you an idea that you are contracting the right muscles. In the end, pelvic floor physical therapy can help your incontinence. It may prevent it from worsening in the future, but it's unlikely to cure your incontinence unless you just leak maybe once a day. And most of my patients do not come in with that complaint. It's usually pretty bad. This is another option we have for stress incontinence, which does not involve surgery, and it is called the urethral insert, also known as a femcell. I do have a sample here in my pocket. It's just a sample, and you can pass it around so you can feel what the insert feels like. Essentially, it's a plug for the urethra. Here in this picture, you see the bladder, and this is the tube where the urine comes through. You can insert the plug inside, and it blocks the flow of urine. Now, you're thinking, well, what happens when I need to void? Well, in order to use this effectively, you have to be comfortable removing it before you use the bathroom and putting it back in afterwards. So you have to have a fair amount of manual dexterity and flexibility to reach the urethra. I usually use this for women who may only leak when they go to the gym or something, where it's really centered around certain activities. And they say, well, before I go to the gym, I'll put this insert in, I go and I work out, and then afterwards I take it out, and then I don't need it for the rest of the day. So, but it is a nice option that's available to the right person. If you didn't feel comfortable removing an insert a couple times a day, another option is a pessary. You may have heard of pessaries, which can be used for prolapse, but we also have anti-incontinence pessaries. In this picture, you see that there's a little ring that is placed inside the vagina, like the diaphragms they used to use a long time ago. And there's a knob, and as you can see, this knob pushes on the neck of the bladder so that the urine cannot slip through, because now there's an increase of resistance. The good thing about the pessary is that it really only needs to be removed every couple of months. So if you have, if I have a patient who's not comfortable removing it, I just have her come back every 3 to 6 months for me to remove it, clean it, and make sure that the vaginal tissue looks good. But I do have a lot of patients who either do not want to have surgery or are not well enough to have surgery, and this is a great option for them. The last conservative therapy that I'd like to mention for stress incontinence is vaginal estrogen. And you're wondering, how is estrogen going to help me from leaking? Well, let me tell you, when you've gone through menopause, either because you've gone through the natural change, or maybe you've had a hysterectomy and your ovaries removed, you lose the estrogen that used to thicken and strengthen the tissue in the vagina, the bladder, and the urethra. By supplementing this estrogen again with either a pill, a cream, or a ring, you restore the lining of these organs. It also improves the muscle tone, and it brings more blood flow to this area. And so one of the first things that I do when I see a new patient is I examine them, and I can see that the estrogen, there's been a loss of the estrogen effect. I recommend an estrogen cream or some sort of supplementation. And you don't need to take a pill. Actually, they've done studies, and when you take estrogen orally, it can worsen your incontinence and not improve it. So I use a cream or something that's just in the local area, just in the vagina and the bladder. Okay, so you're thinking, well, what if I do want to have surgery? All those things sound great, but I want the best, possibility of cure. Well, if you want the best results, you're going to have to look to surgery. And we have 2 types of surgeries. The first one is a urethral bulking injection, and I'll describe that in detail. But that's nice because it can be done in clinic. You don't need to have any general anesthesia. But really, the gold standard for stress incontinence is the Sling, and I'm going to describe both of them in a little bit more detail. First is the urethral bulking injection, and in Hollywood they inject their lips and they make their lips thicker and more supple. It's the same thing, but for the urethra. Here you see the urethra, and this is a picture through a scope, and it's looking up through the urethra where the bladder opens up. So that's what you see. This is the urethra, and it's opening into the bladder. Look how wide open that is. And then and that's before the injection. And then we put a tiny little needle through the scope and inject this material, either macroplastic or coaptite, and then we inject it in 3 different places, and it causes a bulge, which blocks the flow of urine, just like a washer would with your faucet, okay? Again, this is a procedure that we can do in clinic. You don't have to have any general anesthesia if you're worried about your heart and your lungs and your ability to withstand general anesthesia. And we just give you a local numbing jelly. It's very well tolerated. Now, the injections work well, but the best thing for stress incontinence is the Sling. Here is a picture of a normal urethra. This is the muscle, it's nice and thick. This is the hole in the middle, and it's petite. And then when your urethra becomes incompetent, this hole is widened, and this muscle is thin, so it can't contract anymore when you're in the, you lift something or you cough or you sneeze. What the sling does is it sits underneath the urethra and supports it and partially compresses that opening so that whenever you have activity, you're not going to leak urine. There are two different places where we put a sling. One is the retropubic approach, and I think of it as a little V where the two ends of the sling sit behind the pubic bone. And then if you've had a lot of surgeries and you may have a lot of scarring up here, we can also do the sling where it goes more in the thigh, and that's more like a U shape. And both of these therapies have a greater than 90% chance of significant improvement or cure for stress incontinence, and they last for many years. Here's another slide just to describe the sling. Again, it has the highest success rate and is the most durable option as far as surgery goes for stress incontinence. Surgery takes about an hour, and the recovery is quite fast. I want to just pause for a second and address this issue about mesh. Now, you all watch TV, you're educated, and you know what's going on. You've probably seen a couple of commercials regarding mesh and the FDA warning. I want you to understand that that mesh warning is for mesh used for prolapse. It is not regarding mesh for the slings. Slings have been around for a long time. They've got a great safety profile, and the FDA has not passed any warning for mesh for slings, okay? So if that's a concern, you can consider that allayed. Okay, so now we've gone through stress incontinence, the non-surgical options, and also the surgical options. We're going to shift gears a little bit and talk about urgency incontinence. When I have a patient who has stress incontinence and urge incontinence, I ask them, what bothers you more? Leaking when you lift, cough, or sneeze, or not making it to the bathroom in time? And almost every time they say, I hate that I have to rush to the bathroom and I'm dribbling as I'm running to the bathroom. Why is that? It's because you have no sense of control. You have no idea when it's going to happen, no warning. Whereas with the stress incontinence, you know, oh, if my asthma is bad or if my allergies are bad, I'm going to leak more. If I go to the gym and I lift weights, I'm going to leak. At least then you can predict it and you can wear certain clothing or maybe wear a heavier pad. With the urge incontinence, it is very anxiety provoking. What causes urgency incontinence and overactive bladder? Because overactive bladder and urgency incontinence are all part of the same spectrum. Well, I have a little cartoon here. A normal bladder fills to the top, and then when it's socially appropriate, empties on your command. Whereas an overactive bladder may not even reach it to the top, starts feeling a little uneasy, and contracts on its own accord. Okay? So what happens is you're voiding more frequently. I have some patients who void every 15 minutes, every 30 minutes, day and night. Can you imagine what your life would be? What kind of life can you have if you're going to the bathroom every hour, every 15 minutes? Can you sleep? No. So, that's what's happening is you can't even fill maybe to 1, 2, 3 ounces, and the bladder's like, I don't like this, squeezes, and then you're running to the bathroom. And if you're extra unlucky, you leak. Okay? Again, now that we understand the cause of the incontinence, we need to target that cause for treatment. So the goal of treatment is to calm those spontaneous contractions, those involuntary contractions or bladder spasms. We can do this through a variety of ways. First, I will describe the non-surgical options and then go to the surgical options, just like I did for stress incontinence. The non-surgical options include behavioral modification, again, pelvic floor physical therapy, vaginal estrogen, and then medications. This is what you can do to prevent urge incontinence and also overactive bladder symptoms. I have here 6 steps to continence. First of all, limit how much you drink. A lot of people think that if they have urgency and frequency and they have infections, they just need to drink all day and flush that out of the bladder. Well, remember, when the bladder cannot even fill halfway before it starts to contract, if you're drinking all day, you're just going to make it worse. The bladder's going to be contracting all day long. So limit your fluid intake to about 4 to 6 glasses of water a day. If you are voiding a lot at night or have a lot of leakage at night, don't have much to drink after dinner time. Sips of ice, maybe a sip of water if you have to take your pills. Avoid caffeine and alcohol. And that is because caffeine and alcohol are bladder stimulants, and they make the bladder even more unstable, contracting more frequently. Some patients come in and you can just tell that all day long fluid is pooling in their legs. Really a lot of swelling. What do you think happens at night when you put your legs above the level of your heart and you're sleeping? Well, all that fluid rushes down, gets into your heart, goes into your kidneys, and you make a lot of urine at night. So if patients have a lot of swelling in the legs and they're peeing, 3-4 times a night, I said, go ahead and elevate your legs around 3 o'clock, 4 o'clock. Get that fluid off earlier before you go to bed, okay? I also recommend time voiding and double voiding. And this is just to keep the bladder as empty as possible. You want to empty the bladder before it sends you a trigger, because usually when it sends you a trigger, that's followed by incontinence. So peeing every 2 hours or on a schedule, whether or not you feel the urge, because you don't want to wait for the urge. Then it's too late. Pelvic floor exercises also help, and here's a picture which describes how it helps. This is your pelvic floor muscles. We discussed that. And what happens is that if you contract your pelvic floor muscles, it sends a message to the bladder which suppresses that contraction, that bladder spasm. So if you feel the urge to pee and you can't make it to the bathroom in time, contract your pelvic floor muscles, and that might shut off the contraction, give you a little bit more time to get to the bathroom. I also recommend a voiding diary because it gives you a little bit insight on how your bladder behaves. How much can your bladder hold before it decides to squeeze on its own? How often am I peeing during the day? What activities trigger my leakage? And if you jot down this information over a couple of days and look over it, you may realize, wow, if I wait to 3 hours, I will leak. Whereas when I peed every 2 hours, I stay dry. And it gives you some control over your bladder and therefore your life. We had discussed vaginal estrogen previously, and I just want to describe how it helps with urgency incontinence. It improves it keeps the bladder calm by decreasing some of the spasms, and it does this by strengthening the wall of the bladder and improving the muscle tone. And this is just the cream that you can use. It also comes in a ring if you don't want to deal with something messy. We have lots of formulations of estrogen. The first line of therapy, besides physical therapy, behavior modification, and estrogen cream, is actually medications. Medications are classified into 2 different groups. The group that's been around the longest are called the anti-muscarinic medications. And what they do is they relax the bladder so it doesn't have all these spasms. We have medications that are available as a pill, a patch, and a gel. And they can also decrease their frequency and urgency because your bladder is not contracting throughout the day. I'm sure you've heard of these medications before, maybe seen them on commercials. Includes Ditropan, Detrol, Vesicare, Toviaz, Enablex, Centura, Oxytrol, Gelneek, lots of medications out there. In the end, they're very similar on how effective they are, but they do differ in the side effect profile. These medications can commonly cause dry mouth, constipation, and blurry vision. Those are the most common side effects that we see with them. Until recently, the anti-muscarinic medications were really the only option we had for overactive bladder and urgency incontinence. But just very recently, there's a new medication called Myrbetriq, also known as mirabegron, and this also relaxes the bladder and allows it to store more. It also decreases frequency, urgency, and urgency incontinence. The nice thing about this group of this medication is that it does not cause constipation and dry mouth. So patients come in and say, well, I tried the Vesicare and it helped me a little bit, but I really could not tolerate the dry mouth. The next thing I do is, refer them to this medication to see if they can get the same benefit without the side effects. All medications have side effects, and mirabegron is associated with a slight increase in blood pressure. Some patients feel like it works too well and they have a difficult time emptying their bladder. Some patients have a little bit of a headache or irritated nose and throat like you would have with a common cold. Now, if you try the medications and the conservative therapies and you really have not had any improvement in your symptoms, we actually have more things available than we used to. There are office-based procedures and small surgeries which address urgency, frequency, and urge incontinence. And these options include injection of Botox into the bladder wall. We can also use electrical currents to calm the bladder down, and we can do that either through percutaneous tibial nerve stimulation, also known as PTNS for short, or interstim sacral neuromodulation. This is a really exciting time for us because until recently, you basically just had the pills. And if the pills didn't work for you, you were kind of out of luck. But nowadays, we have 3 great options for treatment beyond the pills. So it's really exciting time for urgency and urge incontinence. First, I'll talk about Botox, and I'm again talking about Hollywood, but you know how they inject it in the forehead and around the face so you don't have wrinkles. Well, it's the same idea, but for the bladder. Remember, overactive bladder and urgency incontinence is caused by these involuntary contractions. Well, when you inject Botox into the bladder wall, it, decreases those contractions so you have more time to get to the bathroom. You can hold more than just 2 or 3 ounces. And, I've had a lot of great responses to this therapy. It's also really nice because it can be performed in clinic. I give you a little numbing jelly, some lidocaine to coat the wall of the bladder, and then inject the Botox into the wall of the bladder. The whole injection part takes about 5 to 10 minutes. There's some things we have to do beforehand and afterwards, but it's very well tolerated. The great thing about Botox is that it lasts 6 to 9 months. That's 6 to 9 months where you don't have to take a pill every day, you don't have dry mouth, you don't have a headache, and you have the benefits of therapy. And we know some people, some physicians who have been doing it for very long and have injected patients for even 15 years, and there's a sustained response to it. So it's not like this year it works, but maybe next year it doesn't work as well. So this is a nice option that we have, and it was just actually recently FDA approved for the bladder. Now I'm going to talk about the two therapies that we have using electrical current. The first one is PTNS, and we send an electrical current through the nerve that runs behind the ankle and goes all the way up towards the bladder. And this calms the bladder down. The great thing about this therapy is it does not involve any surgery. You go to clinic, you see this lady here, she's sitting on the chair. We put a little electrode pad on there and send the electrical current up towards the nerves that control the bladder. And you don't have any anesthesia, anything like that. Unfortunately, it does require 12 weekly sessions up front, and then you have to come back once a month for a touch-up therapy or maintenance therapy. I have patients who, some of them come from Virginia, Tennessee, really far away, so that's not really an option for them because they couldn't come every week for 12 weeks. So if you live here locally and don't want to have a surgery and are interested in this, this is a nice option for patients who have tried medications and have not had a good response. Lastly, I'm going to talk about interstim sacral neuromodulation. This is another therapy that uses an electrical current to keep the bladder calm. I performed the surgery. I perform this procedure through 2 small surgeries, and both of these surgeries are done without general anesthesia. It's like a light anesthesia. During the first surgery, place a small thin wire or an electrical lead, here's a little picture, that goes down to the nerves that control the bladder. And then you go through a trial period of 10 to 14 days. And if you have a good response to it, we do the second surgery, which is basically to take this battery and attach it to the lead and then implant the battery. The battery itself is the size of a sugar cookie, and we usually put it in the back pocket area where it's a little bit kind of fatty and you won't feel the battery itself. If this works for you, the battery lasts for 5 to 7 years. So most patients don't need another surgery for 5 to 7 years. Okay, good. This is a table that I made that describes each of the 3 therapies that we have for overactive bladder and urgency incontinence when medications no longer work. On one side, you see the advantages. On the other side, you see the disadvantages. So, I have to really go through this with patients because they want to know what's the right therapy for them. Because someone may be a great candidate for Botox and not a good candidate for InterStim, or vice versa. So with Botox, the advantage is that it can be done in the clinic. You come to my clinic, you leave an hour later, and if you have a good response, you're good for 6 to 9 months. There is no permanent implant. Now the disadvantages is that it only lasts 6 to 9 months. So unlike InterStim, which can last 5 to 7 years, if you respond to this, you'll be coming to see me once every 6 to 9 months, which is actually not that bad compared to medications. The other disadvantage is that it can cause temporary urinary retention, and that's because the Botox may make your bladder just a little bit too quiet and can't quite get all of the urine out. That happens in about 10% of patients, and for that reason, you have to be willing to catheterize yourself in case you're part of the unlucky 10%. So if you have a bad tremor maybe, or if you had a stroke where you don't have the dexterity to catheterize, this may not be the best option for you. The next option here is PTNS. Again, it is done in the clinic. You don't need any surgery, and we may numb up a little area on the foot, but really no anesthesia is required. There's no permanent implant, unlike the InterStim. The drawback is you have to come to the clinic once a week for 12 weeks, and then once a month to maintain this therapy. And lastly, we have InterStim. The advantages are that if you respond to therapy, it'll last for 5 to 7 years, which is the life of the battery. Another benefit is that you get to go through a trial period. I put it in that little wire, and you go for 10 to 14 days. If you respond, great. If you don't respond, I just take the wire out. It's a very minor surgery. Some patients also have fecal incontinence, and if you think people are embarrassed about leaking urine, they're even more embarrassed if they have bowel accidents. And the good thing about InterStim is that if you have both, it can help you with both. And then it can also help patients who don't empty their bladder all the way. They're in this catch-22 situation. When I leak, but then when I go to the bathroom and try and empty, I also can't empty out. And they have a lot of urinary tract infections because they don't empty all the way. And in those patients, it can help them empty and also reduce the urge incontinence. Now, even though they're both surgeries are short and you don't require general anesthesia. Here's the disadvantage. Okay, if you have something metal implanted in your body, guess what? You cannot have an MRI, especially in the lower part of your body. And that's because there's a little metal piece, and the MRI is a big magnet, and they move the pieces around and cause, heat or something, pain. So if you require MRIs on a regular basis, maybe you have multiple sclerosis or something like that, you cannot have an InterStim. Okay, I hope that really outlines for you the advantages and disadvantages of these therapies. And I really go through these because there's not one therapy that's perfect for everyone. I really have to consider your other health issues, your social situation, how far away you live from Raleigh, and fashion it so that it's a good fit for you. Okay, we've gone through a lot of information, and I'm just going to summarize some of our key points for tonight. First of all, urinary incontinence can adversely affect your health and your quality of life. That's a no-brainer. Obviously, you're here because you realize that. Stress and urgency incontinence are different. They're caused by different mechanisms, and therefore, treatment therapy is different. Many people have mixed incontinence, which is a combination of both stress and urgency incontinence. When you have mixed incontinence, we should really address both types in order to get the best results. Here I've got a lady jumping on a trampoline. That's stress incontinence. Whereas this lady is rushing to get to the bathroom. That's urgency incontinence. They are not the same thing. They're not caused by the same problem, and the therapy do differ. We have effective conservative, which means non-surgical treatment options for both types of incontinence. That includes medications, vaginal estrogen, pelvic floor physical therapy, urethral inserts, and pessaries. And for those who do not respond to non-surgical options, we also have office-based procedures and minor surgeries with very encouraging success rates. And these include Botox, PTNS, and InterStim for urgency incontinence, and the Sling and injections for stress incontinence. Okay, we're on the very last slide, and I just want to leave you with a parting thought. Poise pads cost about 50 cents a piece. Depends are about $1 a piece. If you can be free of these two things, your freedom is priceless. So really look to your doctor, get educated, and seek treatment if this is something that's really hampering you and affecting your quality of life. Thank you.